Right. So all of you are very experienced, and in my 30, 40 years of experience, this is first time I've seen such case that might attract you, and some of you will must have seen this as well. So this is 56 years old lady who was admitted with unstable angina, and she actually its previous history has hypertension, but no other risk factors. There was some anxiety and stress in the history. There was no previous history of MI. All the bloods were negative, normal. The troponin was negative, and there were STT changes in the ECG, as you can see from V1 to V4. And we took the patient to the angioplasty as an unstable angina. And when we put the patient on the table, you see this is the ECG the patient had, and with normal blood pressure of systolic 140. And when we took the picture, so there was impression that there may be some LAD totally occluded, which was confirmed when we did the cranial view, as you can see from here. So it's a totally occluded LAD. And then we actually, before we proceed for the, you see, catheter for the right coronary artery, and something happened, you see, we were changing the catheter to RCA, patient becomes unstable, severe chest pain, fall in blood pressure, and became pale and clammy. And patient started dropping her blood pressure and started having the ST rise of more than 3 to 4 millimeters elevations. And the patient became clammy, she was in shock, she started having arrhythmias, VT spells. So the question is, and you can see this is the frame from the angio lab. So she was just going into cardiogenic shock, and with pressure down to 70 to 80. Now the question is, to the panel, what is likely event that has happened and what to do next?
Afsar, have you given any nitrate when you took that picture?
Yes.
But no, we didn't. I mean, one by one, everyone is experienced. So what could happen? Because you see, we are in really a very difficult situation because there was no on-site intervention available. So what to do next, and what is the likely event? What has happened? Anyone who is from the
air embolism to the right coronary artery.
जनरल स्वेल को माइक दीजिएगा.
Air embolism was it possibility at that moment?
Yeah, that is one possibility, but I couldn't see any air. If you want to see the pictures, I very carefully seen there is no air.
So Afsar, so if you look at the arteries, they're quite normal and smooth. So one of two things, either severe spasm, which I've seen that before, and with the left main completely blocked just by after removing the catheter, and by taking the second one and giving nitrate opened up, or this is a dissection, because that LAD looks like there's abrupt occlusion, whether there's a thrombus or not, it looks maybe dissection, and maybe there's an ostial left main dissection.
Right. Any other thoughts? Let's see the other. What do others think? And then I just 3 minutes.
Assalamu alaikum, Afsar. It's a great case. We've seen the left system. We haven't seen the right. Some things might have shot down the right side because I think the inferior leads showed some ST elevation of some sort. If you show us the previous slides, if you show us the previous slides, before the last shot. Yeah, so this is the last pictures, and afterwards when you show the ECG, 2 and 3 are showing some changes. Look at those leads.
Yes.
There's some elevation in those leads, 1 AVL, 1 and 2. And in AVF there's some elevation also.
So in this situation, what would you do?
I think
Sir, it can be catheter-induced dissection to left main. I think I would like to take the left guide immediately and see and take the picture of left main.
Yeah, that's one option, but other is to take pictures and take the right shots also. Restudy this left system, what happened. If it looks all right, then study the right.
But the problem is that the patient is crashing down and we haven't manipulated anything with the right coronary artery. And her present...
I agree with you. What I did was actually,
Yes.
see, this is what we did was actually, I think we should try to make patient comfortable. Morphine, IV fluids, oxygen, query inotropes, heparin thrombolysis, transfer to tertiary care unit. I mean, all these possibilities were kept in mind. But fortunately, the patient started having good pressure with these IV fluids and sport. And this was the right coronary artery. Now, what should we do the next? Mohanad, what do you think?
Re-engage
I mean,
the left main
gonna
and
have-
put down a wire in circumflex and then see the picture.
Another
You're going to
possible.
have to look at the left
Though
system.
this is a radial approach probably, but one possibility, if this was a femoral side, this could have had actually a bleed at the site of puncture, which has got
but
some
not
problem going
giving
on. But then this is a
VTs.
radial access.
VTs and
it's too. This
You
is,
know,
this
after
is a
this, you'd
coronary
study the left
complication.
again, see what's going on.
Now come back and
Yeah,
see
this
the
is a
left again.
coronary complication, isn't it? The speed of what happened tells you it's something there in the left coronary system. Because something
Do you
just.
think this patient has occlusion before or during the procedure, or what any thoughts about this? In the
Sorry?
history, you see unstable angina, no previous history of MI, no Q waves on ECG, and this is a totally occluded LAD. Is it an acute occlusion, or what do you think?
I mean, as I said, I've seen this with severe spasm, or it could be a dissection that expanded back. So you'll have to inspect.
so
the
let's
right
let's
place.
see what do you have in.
Okay, let's go and finish the case because
Sometimes
my
air
slide
can
is
surprise you.
see,
You don't realize there's
it's
air
not that
being pushed down.
Okay,
Right?
so patient started having better blood pressure, and you see this is the picture. Next picture.
Yeah. Severe spasm.
I mean, this is to
No,
be honest. I have not seen
Mohammed,
this
I
case.
think it's more likely to be air than spasm. I think the way it happened, it must have been some. People don't realize we don't fluoro everything, but air is the most likely thing which went down the RCA, the LED.
Yeah, I mean, you might be correct. Often with air, you see kind of it starts kind of almost biphasic flow, just jumping slowly after you do. The only reason I'm saying spasm because I've seen that before. One of my fellows was doing a case and put the diagnostic catheter. You could see the arteries started in a decent kind of diameter, if you like, and all of a sudden everything started to close down. And he moved the catheter, and the lady crashed down. Got in a micro, and the left main was completely closed. With nitrate, it opened up without any issue. But air is always a possibility. Although, if you look at the images, that was the appearance even from the beginning. So whether when they were testing when the flooring,
Can we
it's
see the first few images again, Afsar? Maybe
Yeah, sure.
they will suggest something. The sin is, the first views.
Yes, that's the abrupt occlusion.
Let's see
of the
some
LED
running
plasma
images.
spasm.
Beautiful images. Otherwise, it looks like it's shaped of LED.
I mean,
It
one
just
thing interesting
there's
you
an
can
abrupt
see-
ending.
Next
Lots of
slide,
time
I mean-
we don't realize, and we must save the fluoros also. Initially, because unless we de-air, sometimes I get surprised by slackness. Although people in techs in UK would be much more efficient, but lots of techs are very careless in how they de-air the system. So to
I
me,
think
it's
if you
just
carefully
air down
see,
the system.
Or severe
I
spasm.
pushed you see, I gave a forceful injection, and you see it's moving. Something is moving actually.
So it must be
it's
air.
again-
It must be air.
So are you suggesting
but
that this
air-
is
air is
basically a
visible.
thrombus which is actually traveling down?
The thrombus doesn't just push down like this.
Very
that.
unlikely.
It has to be air.
I think my personal feeling is that it could be a spasm because you see, if
Yes.
you I will show you the echo as well. If you see the last picture,
Young female and
Afsar, when this occlusion was there, patient was stable. So
The patient is not
she
stable.
crashed
Patient is
after
not
those
stable.
first few views,
VTs and
and it seems something happened. And the only thing I can think of, the more air went down the system, and it went down
I mean,
the
if you see
circumflex
this
also.
LED,
It went down the
caliber
left
of
system
the
also.
LED. I would just take Mohanit's point. If you see the caliber of the LED, if it goes into spasm, I think that can occlude the heart. That is one possibility. And this is what happened in Takasabo actually. It's a live case of Takasabo, like where is neuroendocrine, you see mechanism happens and acute spasm or thrombus, and then it washes away. But fortunately, when we did the echo, there was no Takasabo. So it's all this is the post-angio echocardiogram, which doesn't show any small motion abnormalities. So this is something you see, which is probably one of the something which is not clearly known, but spasm or thrombus, but thrombus doesn't wash away like this. Spasm probably is the most likely, which I think. I don't know if anyone has seen this case. So what is the etiology we have discussed and further management plan? So how should we just leave it alone, or what would this patient be labeled as? Is it acute coronary syndrome or NSTEMI or what will, or is normal?
I think the way it
Coronary
cleared
artery
within
normal.
minutes, it has to be air as far as I'm concerned.
If
Okay, then what happened next?
The patient
I mean,
made
these are the
uneventful
possibilities
recovery,
we have
alhamdulillah.
already-
so
And
the
did the
patient
patient have
was
any enzyme
hemodynamically
rise?
stable at that time, except that was having some runs of VT, but otherwise
Enzyme
blood
rise.
pressure was okay. And you just stopped there for a while and thought out that what has gone bad, air or the spasm. So did you give something to relieve spasm there, and oxygen,
because
anything?
the patient
And-
with IV fluids and reassurance, she was a bit anxious, tense. So I think with reassurance, morphine, I think the blood pressure came up and the things went off. I think it was probably spasm. These are the other possibilities I mentioned: dissection, thrombus, air embolisms, a SCAD, or anything else. I think.
Any
Afsar,
more
did-
images after a few minutes?
No, but
Just
that
a
is
feeling
the-
that the dissection and thrombus
I
can't
took
just
one
go
or
away.
two.
Afsar, did you proceed on to open the LED eventually?
It was reopened on its
It was
own.
with hand injection. It
It,
was
it
therapy.
just cleared
LED.
it cleared on its own.
Oh, it got
Yeah.
cleared. Okay.
So did,
right.
did the
Yeah,
patient
yeah,
have an
it
enzyme
cleared
rise? Enzyme elevation? Doctor,
Enzyme-
Yes, there was 1,000 troponin. Yes, but 10,000 times rise troponin. But the echo is normal.
So
The
what
echo
was
was
this
normal.
before the angiogram?
no, this was only one reading, or did he do two readings? Two readings, 2 hours apart.
Before the angiogram, it was troponin
They
negative.
don't make
Sorry, I
mistakes
showed
in
you it was
UK,
troponin negative.
Bilal.
Why not?
The echo remain normal.
Very
That's why I troponin negative, no ST changes,
Troponin
no Q
negative.
waves. And so I think probably this is what I wanted to share with you. I thank you so much. Sorry, my flight is just at the back. After I congratulate you and all my colleagues and friends. Really, I enjoyed this session, and thank you
Thank
so
you
much.
for joining us
Very
and
much.
contributing.
Thank you for joining
Thank
us.
you,
That's
sir.
great seeing you.
Thank